Okay, let's spend a little bit of time talking about some of the advanced procedures that we need to consider when thinking about dose and CT. Particularly, I want us to be able to start to think about protocols and how CT protocols can be modified to decrease or increase patient dose. Specifically, we also want to be considering how clinical history might have an impact on patient dose, as well as our screening procedures, scheduling, patient education, as well as physician education or ordering person education, informed consent for the patient, how to talk to them about radiation dose, medications, mobilization, and examination instructions. Of course, we're not going to be able to talk about all of that in this presentation because it's pretty brief, but it's something that's we're going to be weighing protocol by protocol this trimester. And largely, we want to also be thinking about how to respond to sentinel events. So what's the big deal? Why do we care so much about dose? This I found just today from the ASRT forums. A question from a technologist asking about an amount of radiation, 800 milliroentgens per hour, which is getting through the CT door and exposing personnel. So clearly this is in the news, this is all around us, it's in our communities, and that's the purpose of this presentation, to help us better understand CT dose, both occupationally and for the patients. So when thinking about radiation dose in CT, radiation protection of both our patients and personnel in medicine is guided by two triads that are intended to ensure that medical radiation workers work within ALARA, and that's as low as reasonably achievable, philosophy of the ICRP. So one triad deals with radiation protection actions, and then the other triad addresses radiation protection principles. Okay? So radiation protection actions include the use of time, shielding, and distance, those three things. And all of them are intended to protect both the patients and personnel in radiology. So, for example, because a dose is proportional to the time of the exposure, to protect personnel in CT, it's essential to minimize the time spent in the CT room during the exposure, and that's both for patients, parents, and personnel. Distance, on the other hand, is a major dose reduction action because the dose is inversely proportional to the square of the distance. So this is related also to that question about the CT door. Shielding is intended to protect not only the patient, but also personnel and members of the public. And we'll be talking about CT shielding considerations throughout this trimester. So because scatter radiation is present during a CT exam, it strikes the walls of the CT room, the walls and the doors need to be shielded to protect members of the public and other radiation workers present outside the room. Let's talk a little bit about principles. Radiation protection principles deal with these three things: justification, optimization, and dose limitation. Okay? Justification means we need to have some net benefit associated with every radiation exposure. So this requirement is intended for referring physicians and is one effort to reduce doses to patients undergoing X-ray examinations. And you'll even see this can be related to things like reimbursement. Medicare is very interested in whether or not an exam was justified. Optimization largely falls on the technologist, and this is a principle intended to ensure that every dose delivered to a patient is kept, again, as low as reasonably achievable. It's economic, social factors, and all relevant technical protection practices have been considered in order to ensure that the dose is optimized, like discussed in our article, and that the image quality is not compromised even as we reduce the dose. So that's dose optimization. The final concept is dose limitation, and this is a major integral component of regulatory guidance on radiation protection. So in the case of Jacoby Bryant, the major consideration here is probably dose limitation. Even though optimization plays a role and justification play a role in this, the question of dose limitation to me seems to be the most pressing. So this concept addresses the dose that an individual receives annually or accumulates over a working lifetime, and these doses should be within limits established by international organizations like the ICRP and other national bodies like the National Council of Radiation Protection, as well as any state governing body and provisions and ethics created by the ASRT and the ARRT. So these recommended limits are intended to reduce the probability of stochastic effects and to prevent detrimental deterministic effects. So thinking about Jacoby Bryant, think both about stochastic and deterministic effects, and it may be worth looking up on Wikipedia and seeing a little bit more about what stochastic and deterministic effects of radiation we're talking about in that case. And these dose limits are outside of the scope of this discussion, but these are things that we will continue to talk about both as we're talking about CT protocol design and creation, as well as in the fall when we talk about radiation protection, radiation biology. So one final thing that may be worth looking at, especially as you're putting together your thoughts related to the case of Jacoby Bryant and other misuses of CT radiation, is this American College of Radiology white paper, which you can search on Google. It's worth reading over and familiarizing yourself with some of these concepts that have been kind of deliberated over by radiologists in the field.